Our third speaker that we'll have is Dr. Deborah Loxton. She'll be joining us virtually. She's the director for the Center for Women's Health Research, the University of Newcastle, and the director of the Australian Longitudinal Study on Women's Health, the largest and longest running study of its kind in Australia. Women's health over the lifespan has been at the center of Professor Loxton's research for over 2 decades and remains her primary research interest. Her main areas of expertise are maternal morbidity and mortality, the impact of violence over the life course, and the translation of research into policy. Professor Loxton is a member of the National Women's Health Advisory Council, convened by the Australian federal government to address gender disparities in health and science delivery and outcomes.
Thanks everyone for your patience. I'm aware that some people online haven't been able to see some of the slides, so hopefully you can see these because I'm online. Thank you for having me today. It's a real pleasure to join my co-panelists who are just doing the most amazing work. I'm here taking mad notes while I'm also trying to think about what I want to say. And thank you, Irene, for the introduction. It's been my pleasure to be one of the 2 directors of the Australian Longitudinal Study on Women's Health for the past, I can't remember how many years. And we've been working in the area of women's health, of course, for more than 2 decades now as we hit our 30th year. Today, I'm going to talk about providing research evidence for health policy over the long term using the longitudinal study as a case study. The longitudinal study was born from activism and political will, and through a large stakeholder consultation process was eventually born in order to inform policy and practice, and has been doing that, as I said, for the last 30 years. The longitudinal study, I'm just shrinking something on my screen there, sorry guys. The longitudinal study is conducted jointly by the University of Newcastle and the University of Queensland in a 30-year partnership, which is really incredible in academia to have that long relationship with our colleagues there in Queensland. Both teams work very closely together and have done for 3 decades. We are conducted on Awabakal, Worimi, Wonnarua, Darkinjung, Turrbal and Yagara traditional lands, and we pay our respects to those traditional custodians and those of the many lands across Australia where the participants in our study reside. When Irene first asked me to talk about the longitudinal study and how it informs policy, I went on this little historical journey thinking about how important the origins of the study actually are to the way that we conduct our business. Back in 1975, we had the United Nations International Women's Year and their World Conference in Mexico really driving women's rights at the tail end of second wave feminism. Nationally, we had a Women in Politics conference and the establishment of the Women's Affairs branch in the Department of the Prime Minister and Cabinet, the first such office that we'd ever had in Australia. That office still exists 50 years later. At the same time, the women's health movement was challenging the status quo by raising taboo topics of abortion, contraception and violence, and rejecting biological models of health that focused on reproductive health as the only thing that made women's health. The National Conference on Women and Health, also held in 1975, recommended the adoption of the biopsychosocial model of health that I'm sure many of you are familiar with, insisting that in addition to biology, we must take into account the psychology and the social context in which women live in order to really understand women's health and women's healthcare needs. This group also advocated for a national policy on women's health. Our Prime Minister in 1975 said, "Good healthcare for women must be based on adequate and sensitive research into causes and methods of treatment, but ultimately it can only come from a correct understanding of how women feel about their bodies and a correct understanding of the lives they live." 50 years ago, I feel that this quote is still relevant today. At the end of that year, we had a change of government and a shift in priorities as other things came to the fore. Nevertheless, the United Nations Decade for Women and continuing grassroots activism led to the enactment of the Sex Discrimination Act in 1984. And from 1986 to 89, we had a national consultation on women's health. So a lot of things coming together over that decade and a half, until in 1989, we had our first national women's health policy, not just the first in Australia, but the first national women's health policy in the world. It took a biopsychosocial view of health. It included violence against women as a critical issue in health and stressed the need for high quality data as evidence for policy development. This led to the establishment ultimately of the Australian Longitudinal Study on Women's Health in 1995, and in 1996 we had our first main data collection. It is this foundation that led to the core principles and values of the longitudinal study. Underscoring everything is the voices of women and the lived experiences of women. In order to take that biopsychosocial view of health, we have a multidisciplinary research team, the inclusion of clinicians and service providers in the discussions about the current priorities for women's health. And we do continually consult and listen to women throughout our development processes. We do all of this in order to collect and provide high quality data that is useful for both policy and practice. This is the longitudinal study today. We have over 57,000 women from across Australia who regularly participate in survey data collections of the longitudinal study. On this map, one purple dot represents a place where at least one participant lives. And this pretty much looks like the way we live in Australia, with sparse population through the middle and quite dense population on the coastal areas, particularly on the east and west coasts. The longitudinal study is in 4 cohorts. The original 3 cohorts, recruited in 1996, were then aged 18 to 23, so early adulthood, 45 to 50, so approaching middle age and menopause, and 70 to 75, so just reaching older age and retirement. In 2012, we recruited a new cohort of participants who are aged 18 to 23, and you can see that these women are now aged in their early to mid-30s. The next group up, or 1973 to 78, are now in their late 40s and early 50s. The middle-aged women are now reaching older age, aged 74 to 79, and our oldest group are aged 99 to 104. There are about 100 women in this group who continue to fill in surveys on a regular basis. In addition to the regularly collected survey data, we also link this with administrative data that is collected nationally. That includes measurement of things like consultations with family and specialist doctors, information about hospital visits, how long people stayed and what they were there for, in addition to registry data, so things like cancer registries and registers of whether or not people have taken up immunisation. That is a huge body of data that we have access to, and we're very privileged to have it. I noticed in the Q&A that someone had called people data donors, and I really did like that expression. We also collect sub-study data from women occasionally, using some additional funding, usually through our equivalent of NIH. So that has led to us also having some biological samples from some women, including DNA, anthropometric data and physical activity data. And we also have information about the children of women in the youngest 2 groups, so we're able to look at intergenerational issues. By taking a biopsychosocial view and collecting and linking to as much data as we can, we are able to look at multiple research areas over time in a very detailed way, not just focused on bodily systems or disease, but also including things like the impact of where people live, the impact of how people live, and also the impact of health on those things. So how are national women's health priorities set? In Australia, the usual way. The government represents its constituents, and then there are also government inquiries. There's lobbying by individuals and interest groups, but there's also the National Women's Health Advisory Council, which Irene mentioned in my introduction. This council was set up to address a lot of the things that Angela was just talking about in relation to research, but also having a look at biases in the health system, in systems that were really under a patriarchy, designed for men and largely by men. And although a lot of that has been looked at over the years, this council exists to have a look at the systems that drive disparity in the health system and leave women at a disadvantage. I've been fortunate enough to be on that council now for the last 3 years. And how does a research study like the Australian Longitudinal Study on Women's Health contribute? We do this directly by responding to government inquiries. In the last 5 years, we've made 17 formal submissions in addition to more informal submissions in our local connections with government. We provide reports to the funding body and other government departments on request and sometimes by commission. There's the work of the council that I was just mentioning, and we also disseminate information more generally through social media and our website. It's important to note, though, that with such a wide body of data, it's also important to involve other stakeholders and researchers in analysing that data and producing as much information as possible. The longitudinal study data are provided free to bona fide researchers worldwide. To date, there have been over 1,100 projects with 173 currently active, over 1,200 peer-reviewed research papers produced, and 215 reports to government. And it's those reports to government that really have an impact in the policy space. We also publish a data book for every survey that we've conducted, so it's possible for anybody to hop online onto the website and look up the percentage of women in the country who are experiencing a particular disease or who have had a particular life experience, such as domestic or intimate partner violence. These are some examples of our recent policy engagements. We have provided information to inquiries and consultation on alcohol and other drug use. The mental health policy in New South Wales was recently reviewed and we provided information to that. There's also a consultation on refreshing the national framework on chronic conditions, and information from the longitudinal study was also used there, and in the review of access to reproductive health care. So in terms of policy outcomes, it's kind of obvious that we are most likely to influence or have our information included in national women's health policies. The study came from the first national policy, and data from the study has been used in the 2 subsequent national women's health policies. In 2010, information from the study was used to inform the policy development of sexual health, mental health, health behaviours, chronic conditions and violence, and also used to help set those priorities. In 2019, this policy was reviewed, and the current policy, the National Women's Health Strategy, was developed and enacted in 2020. And this time, the study team were involved in consultations, along with the wide consultations the department undertook with different advocacy groups, clinicians and members of the public. And we also provided 10 policy briefs that fed directly into that strategy. In addition to policy outcomes that are directly related to health, we've also had quite an impact in the space of violence against women. The study's collected information on violence since the beginning, and just recently we've provided that information to 4 government departments and had findings for sexual violence used in 6 key policy documents. This is just a quick overview of the policy process as we experience it. Something, usually activism or personal experience or media, will raise issues that will lead to some sort of government inquiry. A few years ago, there was activism and a lot of public interest in contraception costs and access to contraception services. This became a part of the government inquiry into reproductive health care. The longitudinal study data was included in submissions, and the director at University of Queensland and I both gave evidence at the hearings that were held by government. The longitudinal study data was also used by the National Women's Health Advisory Council and several other groups in their own submissions. Ultimately, the policy that came from this inquiry was enacted in February of this year, with $500 million support being offered for contraception and contraception services. One of the most powerful things about a longitudinal study like this is that we not only get to inform policy in the first place or provide evidence for people to make decisions about policy, we can also evaluate the impact of that policy once it's been enacted. So in a couple of years' time, I expect we'll be looking at the impact of this contraception package. Well, I hope this has been a good snapshot on the value of longitudinal data. We've been very fortunate to have been consistently funded through 9 federal elections and both sides of government, 8 prime ministers, 10 health ministers, and about 8 name or portfolio changes to the Federal Department of Health, currently called the Department of Health, Disability and Ageing. In that, we've tried always to be bipartisan and to ensure that the data we provide is about the information that we've collected and a good representation of women's voices and experiences. The longitudinal study came from policy, and we have throughout always included stakeholder engagement. The dissemination of the findings now inform policy, and our hope is that that leads to better health outcomes for women across Australia. The longitudinal study on women's health is managed by the University of Queensland in Newcastle, as I've mentioned. We are grateful to the Australian Government Department of Health, Disability and Ageing for funding, and we are most grateful to the women who provided the survey data. This is me. Feel free to get in touch or to read more about us on our socials or on our website.